this webinar set up by Empower team. And the Empower team works in a collaboration with bringing together a diabetologist, endocrinologist, educators together to improve diabetes care and outcomes in India. And they conduct a series of webinars, and this is one of them. And with that, I invite the founder of Empower, Dr. Amit Dey from Kolkata. He's the diabetologist who had this vision to bring together the healthcare professionals involved in T1D Care. So over to you, Amit, for the introduction.
A warm good evening to one and all. And I guess this is a very important moment for all of us, having our mentors and our peer groups joined in a single platform. So my job today is just to give you the introduction of how Empower came into being. So this all started a year back, where a few like-minded people thought that the care of type 1 diabetes should bring both the clinician and the patient and the advocates involved on one single side of the table rather than putting them on opposite side of the table. So with that, we started a community, a group called Empower Type 1D, which focuses on predominantly sharing research, conducting webinars, meetings, and working with both the type 1 advocates, physicians, diabetologists, endocrinologists towards good clinical practices on a single platform. And we are really happy today that we have our mentors, our guiding lights with us, Dr. Banshi Saboo, Dr. Archana Sada, and of course, Dr. Partha, who's been an inspiration to so many people across the globe with their work, to guide us, to mentor us, and to mentor this group of diabetologists, physicians, endocrinologists, as well as the type 1 advocates, going forward together towards one common goal. And the goal is to bridge the gap in type 1 care to bring better patient and clinical outcomes. So with this introduction to the whole community, I would hand it over to Dr. Archana Sada, ma'am, to tell us about what we had discussed on the collaboration and how the two communities can work hand in hand towards better type 1 diabetes.
Thank you, Dr. Amit. Hello to everyone. I represent TIEUP. You can call it T1EUP or TIEUP, which is a tie-up of exactly what Dr. Amit was saying, that we believe that it takes a village to raise a child. And Dr. Partha, Dr. Banshi Saboo, and myself, since a long time, have been working together, trying to bring the entire healthcare professional community together. But in the last 1 year, with that vision of bringing educators, nutritionists, and the type 1 people living with type 1 diabetes and the community leaders together so that we can reach the last mile. So we believe all of us collaborate in learning, teaching, we learn from each other and reach out to people in every single village of, at least right now I'm talking about India. Of course, we want every child in the world to be taken care of. When we started with TIEUP, initially we had lots of learning on websites and videos in which the doctors from UK of Indian origin had so kindly created teaching modules and contributed. There was a gap during the COVID period. And again, last year, we got together and we had our first national conference specifically focused on type 1 care, which brought pediatric endocrinologists, physicians, diabetologists, nutritionists, and people living with diabetes and the entire community together, and which was a wonderful success. And we have witnessed here so many people right now who have joined in, who were part of it. And when we saw Empower One and these enthusiastic young people led by Dr. Amit Dey, Riddhi, Mehak, everyone, and the kind of work we are doing, we thought, okay, why should we have two reinvent the wheel? Let's collaborate. So we hope today that now onwards, in all the ways of reaching out through webinars, through various forums, we will come together for physician, doctor, HCP training, as well as empowering the type 1 community. Similarly, in the TIEUP conference, we would love to have the Empower T1D presence, where they bring the community and give them a stage to speak up and to tell what they feel, what is their viewpoint and their research, and whatever else that they wish to. Ultimately, it is for you that we are committed. So I'm really happy today is the first collaborative effort, and I really wish all of you, all of us, big success for the same cause. Thank you so much. Over to you, Myra.
Thank you so much, ma'am. We are with you in this vision, and we'll try our best to give and improve the care of T1D in India. And moving forward, I take this opportunity to invite Dr. Partha Kar. Dr. Partha Kar has been the consultant in diabetes and endocrinology at NHS Trust since 2008, and he has been the clinical director of diabetes, and he is one of the pioneers in Super 6 diabetes model that aims to deliver diabetes care differently. And Dr. Partha is also the Associate National Clinical Director with NHS England. And with his effort, it was possible to that continuous glucose monitoring has been available to children living with type 1 diabetes in UK since 2021. And as per the data I have read, in 2019, there were 14% usage of CGMs in UK, and currently it is 98%. So I pause while I say this, and it's a huge number. And in current years, 2024, the closed loop system has been made available with for T1D in UK. So it's a huge thing, and it's a pleasure and honor to have you.
Okay. Since
Over to
Mahira's
you, Dr. Partha,
cut
for your
off,
talk.
I will join in. Very nice introduction. Thank you very much. And thank you to everybody. So I've got some very few slides, and I'm just going to say to everybody, first of all, the opportunity to be involved is a privilege. And I've known Banshi for many years. I've known Archana for many years. And I think what has always struck with me is their desire and passion to improve care. That's the fundamental thing, right? And that resonates with me all the time. And I think that's quite important. And I think the concept that we have now of building a community of everybody together, which has got many forums. And people always ask me, does it have this label, that label? It doesn't matter. It really doesn't matter. You can call it whatever name you want, whether you want to call it TIEUP, is it JDRF, now known as Breakthrough T1D or whatever. It doesn't matter whether it's RSSDI. The main thing is, are people doing something to try and improve care? And little work together all joins up to become good things. So I've always believed in, if people are doing good things, we have a job to come and help support, because they all add up together in the end. So I'm going to try and share my slides if it works. So I do a very short presentation if it works. So I don't know whether you can see it. Can you see it? Oh,
Yes,
not quite.
Yes, sir, it is visible.
Visible is always important. So it should be a bit more than visible now. Okay, so I'm going to say type 1 diabetes care. So why do we settle for second best? Or should we settle for second best? That's a very important thing. You should always aim high. So the first thing I always say with these things is that, if this moves, right. So the first one is a why. I think it's a simple philosophy, why we do what we do, which is what we have said. You know, you got people living with type 1 diabetes and the carers, for them, it's obviously very personal. And I think for people like Archana, Banshi, me, it's part of our lives. We would like to change things as you go along. We have a privilege of being a doctor. We have a privilege of being in a position in society. And I think we try and sort of do what we do. So, and the world beyond everything else, you know, there is a bigger picture in the world, what's going on all around us, but there's no reason we can't focus down as to what we want to do. So I always use this particular thing to make everybody sort of get an understanding what type 1 diabetes involves, right? And the important thing is not everything else in that slide. The important bit is the last line of the slide, which is you have to do that all the time for the rest of your life. This is what I say to clinicians at the end of the day. If you had to do it, if you had to live with it, it becomes problematic. And that's why all these conversations that we are trying to do, why do we improve care? Why doesn't care improve? Care doesn't improve because it's quite a difficult condition to live with. It's as straightforward as that. It's one of the few long-term conditions which needs so much input, has got so many variables to it, weather, time of the month, all of them change things, which is not easy. So people have heard me say this, and I mean this a lot, which is why the concept of a community. We have always focused in healthcare systems around the world, wherever you are, always focuses on number 3. How do we get more doctors, more nurses, more clinicians? The problem with that plan is that we just don't have enough of them. So, and plus, people only spend 99.9%. You're living on your own. The main thing that we're doing here is that we're trying to improve that 0.1% with a trained professional. So, whatever we can do to improve self-management and peer support, and this is the quite important. You got Mehak here, you got Riddhi here, And I think the peer support network that you create, you talk to each other, you help other people, is incredibly important, because we as clinicians can't fill that space because of our time limits, how much of there is in our lives and all that sort of stuff. So that's quite important, I mean, to remember the principles of what we're trying to do in this space. But some of you have seen this slide, and I think this is quite important. And I've always said this, times have moved on in type 1 diabetes care. So there was no care, obviously, no insulin, people used to die. Then you had the pre-mixed in the 1970s. We had insulin strips and self-management being pushed in the 1980s. You had pumps and CGM coming in 2010s. And obviously now you've got hybrid closed loop systems. And you can see that graph about what it means in the life of someone, the shorter life, the disability, the healthy life component. And one of the things that we have been driving, obviously, in the UK, which was mentioned in my introduction, hybrid closed, because, as I always say, it's the best thing that science can provide beyond a cure. And it becomes, so whenever you say things like that, people always go like, well, it's probably because UK is a very rich country. And we'll come back to that in a minute. So that is an important thing to remember. What we're trying to do is increase the blue bit as much as we can. And again, a lot of you have seen this slide, a lot of you have used this slide, and this is, I would say, this is what becomes a part of the responsibility, right? So people always look at this and say, yeah, we've got type 1 diabetes. You are actually losing that 48 years of healthy life years, right? You just lose that. So that's the average life expectancy of anybody who doesn't have type 1 diabetes, 72, and that's 48. So that's the amount of healthy life years you don't have, which is a huge number, right? And whenever I show this slide to a lot of people always immediately say that, it's because, India, poor country, we can't afford everything, we can't do this, we can't do that. So I always also say that is that India you all talk about, but there is also this India, which people also talk about quite proudly. Just been through an election whereby lots of discussions have happened about the growing economy of India. India has actually got a stronger economy than the UK. So when people come to me and say, you've got more closed loops because you've got a better economy, that's not quite true. That's not quite true, because India is quite a powerful economy nowadays. And there's talk about it, India moving into the top 3 in the next 10 years or so. So there is that. There is also this India, which puts a rocket on the moon. And the important bit is there is also all these things are happening in India, right? Rollout of 5G. We are one of the richest actors in the world living in India. So all of this is also part of India, whereby you've got India, which people talk about not being able to afford anything. You've also got an India which can do all these things, right? So the conversation needs to go back to this point and say, I don't think we should accept as a community that we're just a poor country and thereby we should just accept what things are. And due to the hard work of people like Archana, Banshi, etc., we're now moving. We're moving from the point of saying, well, probably BD mix is okay. Well, no, BD mix is not okay anymore. I think that's a big piece of work going on where we're saying, no, it's got to be 4 insulins a day. And it's got to be basal bolus where we can afford it. We've got to have basal bolus with education, with training, because that clearly makes a big difference to people's living and longer. So what are the areas we want to tackle? We want to tackle diagnosis. Needs to be done properly at all the ages. Type 1 diabetes is not just a particular diagnosis of the young. It appears at every group. Prescribing, are you prescribing the right insulin? Are you prescribing? That's an education piece that comes in. Supplies, and again, something that Banshi and others are working on quite hard with the government and everything. How do you get everything in place? Stigma is a big thing, and exactly where all the peer support groups come in to talk about living with it. You've got people very clearly having good lives, enjoyable lives, but at the same time, there is a degree of privilege around it. So how do you help others to get past the stigma? And finally, data. Data is probably king. If you don't have data, you can't convince anybody to give you money to improve care. So I always say, if you had one thing you wanted to change overnight, you wanted to have data sets. You want to have data sets which is available and you're going forwards. So a final few things I always say is that the power of language continues to be important as to how you speak to people when you're going to tackle stigma. I think if you don't understand the power of language, you won't. So don't try and judge other people's life. You got some really good pieces of work in India already, which has happened around language matters. Lots of communities came together. There is one for type 1, one for type 2. But I think type 1 diabetes is there. So I would always encourage those who are listening, if you're a clinician, have a look at it. If you're somebody who's a healthcare professional, pass it on to your clinician or try and see what you can educate other people to do. Which brings us nicely back to people like me. We, as they always say, Fir bhi dil hai Hindustani. So we are brought up in India and we would like to give something back. Many people like us. We have an expertise built over years. We have a training. It's a new world. It's a global India, right? We're all part of it. We are working with local clinicians, and I've already mentioned the name of Banshi and Archana, who have been wonderful allies over the years that we're building. And I think we're building something quite exciting. So over the next few years, I suspect we might have some major changes going forward, which is extremely exciting to go forward. So I would say, think as an example, as I said, BD makes insulin. Why are people on BD makes insulin? What is it that we are stopping? Why can't we move to international guidelines? Don't suggest so. So it's very, very heartening to see the recent guidelines come out, again, due to the hard work of the clinicians concerned, where they're basically saying it's QDS or basal bolus insulin is the standard care. And, why should it be otherwise in India, a country which is one of the richest economies in the world? And if it's supposed to be easier, so who is it easier for? Is it for the person living with type 1, or is it for the person who's giving the prescribing? I think these things we need to always have a discussion about. So why are we saying a lesser care is better? Why are we accepting it? Is it because it's creating more work for us? Is it because we have to go and learn about new things? And at every step, you will always have these challenges, because when we have these with technology in the UK, you have the same problem. People saying, well, I've got to go and learn about it. Absolutely, you do. That's progression of science. So don't settle for second best. I always say to everybody, you got to aim for the moon as you're going forward. So ambition, you got a basal bolus as standard. You should have peer support as standard. We're working on an information portal, which will have everything in one place. And I said before, building a community is extremely important. And that community comprises of clinicians. It will comprise of people living with type 1 diabetes. It will comprise their carers. It will comprise of payers. It will comprise of industry. And models of care, like some of the work that Banshi is doing, Archana is doing, Swami is doing in the south. You got Sujoy doing work in Bengal. All of these things are models of care. There is no one model of care, and I think that's important. There are different models of care, and we just need to go and try and see if we can get 4 or 5 really good models of care. How can we encourage other people to take it? And finally comes a bit about technology. So technology is not going to be that far away from India either, because that's a conversation we are having with a lot of industry to say that what can we do to introduce technology into India. And me and Banshi were having a lovely chat in, believe it or not, in Waterloo Station, where Banshi talked to me about this model, about the group of people who could end up being on pumps and the benefit. And I really like that. So that's a conversation we're having with Medtronic and others to see what can we do in certain states. Example, in Gujarat or somewhere else. What can we do to sort of move things around? So finally, I always say this: a country which can put a rocket on the moon can certainly give the best care to those with type 1 diabetes. I don't accept anything else. And I say this as somebody who's an Indian at heart. So we need to push all our politicians to say, if we can do this, we can do that as well. And you never settle for second best. That is not the India we're all proud to be or should be at part of in 2024. We are all very proud of where India has come from. A lot of you will not have been around in the early 80s and 90s when India was a very different country altogether. And I think people are proud of where India are. And I think that should extend to healthcare, especially in type 1 diabetes. So final thing, I think we can change the statistics together, and these sort of meetings are very important to get people together. Even if 5 people join, 10 people join, doesn't matter. I think even 3 people take away that view that we can work together, and I think you will do well. So that's my sort of view. So I'll finish there. Thank you very much for asking. I'll stop sharing and then see how we go. So thank you very much.
Thank you. Thank you so much, Professor Partha Kar. It was inspiring talk. You well said that India has come a long way, and one day we'll see a changes in T1D Care related to India. Thank you so much again. And with that, I invite Dr. Banshi. I get very few instances where I can introduce Banshi sir. And with all the respect, I welcome you, sir, on behalf of T1 Empower team. And to introduce you, he's the IDF chair-elect for Southeast Asian region. He has been the immediate past president for RSFDI. He has been the secretary for Diabetes India and the past president for AERO. And when it comes to type 1 diabetes, he's one of the pioneer in type 1 diabetes care in India and internationally. So over to you.
Thank you, Myra. Thank you for kind words. Thank you, Archana, Partha. Can you allow me to share my screen? Let me first
but sir, somebody's not allowing you. Is this even possible? I just think this is just, I cannot believe this.
Can you see my slide, sir?
Yeah. Yes.
Is it visible?
It's visible.
Good. Thank you, sir. Thank you. Let me just a minute.
Full screen, please.
Yes, I'm trying to do it. Just a minute, madam.
Once.
Is it full
Perfect.
screen now?
Yeah, yes,
Yes, sir.
perfect.
I'm just trying to. Okay, good. So great talk, Dr. Partha, and very motivating. What I'm going to do in next 20 minutes, what's the mission of type 1 diabetes? And he talked about the vision of type 1 diabetes. Let me start with my first slide. I don't have any financial conflict of interest, but definitely interest for type 1 children, which is I'm having since last 25 years of my practice. This data, I'm sure everybody must have seen that India is having highest number of children. I'm talking of highest number of children, which is 229,000 as per ID of 2021. We are the number one. Next to, US is second one. We are having also number of incident new cases. Again, in 0 to 19, again, number one, it is 24,000. But we are not top 10 countries in the world having highest number of incidents wise. So still, the number of children in our country every year, we have 24,000 children are added, and we have 229,000 children below the age of 19 are already type 1, which is highest in the world. But if you see this data of type 1 index, some data already shown by Dr. Partha, at present we have almost 8,60,423 population living with type 1 diabetes. But what we lost in last 20 years is 9 lakh people because of the poor care, which we could not give it. One more data which is showing here that new people with type 1 diabetes in India every year is 85,770, which is if 91% of them diagnosed. But if you see the previous data of IDF, they are saying that 24,000 children are added, but here it is 85,000 new type 1 diabetes are added every year. It means many of them, more than 60,000 people, must be adults who are developing type 1 diabetes in our country, or both the data are different. But we know that type 1 in adults is almost like the whatever the number of people who are added in the group, 50% of them are above the age of 19. Now, how TIEUP was formed? This is what I just want to give some information. First, I met Dr. Partha long back. It's almost 2015. I was in Diabetes UK. Dr. Partha and we met, and then we met with many Indian endocrinologists who are, the endocrinologist of UK with Indian origin. And we talked about that how they can help. But I was very much impressed by Partha because Partha was working for type 1 in UK, in NHS, and trying to, for continuous glucose monitoring for each and every type 1 who is in UK. While we were here discussing for the basal bolus, we were talking about self-monitoring of blood glucose, and he was talking there for everyone should be on continuous glucose monitoring. And we discussed that, can we do something more for Indian patients? Then he had come out with an idea that we can involve some of the UK endocrinologists who have Indian origin, and we will create a tie-up. And that was immediately after 6 months. We were there in US, and again we met him, and along with Pratik was there, and he had given this idea of type 1 actually education UK program. So this is the full form of tie-up which has been coined by Dr. Partha, and we decided that yes, tie-up will be a good name. And then Jay's became the partner, me, Jay's, and Partha. Partha was invited to Diacon. He was in Ahmedabad. Then we have invited him for multiple times for multiple meetings in India. And Jay's and me, and we decided that we will have a website of tie-up, and all those endocrinologists who are ready, we have created their video, we have taken their PowerPoint, and across the country, we have done some education program for that. And then Dr. Archana Udan, the type 1 queen from India, central part of India, Archana and me, I know Archana since long, but we were knowing each other since last almost 15, 20 years. But then I realized that she is actually working very hard for type 1 diabetes. And I asked only her that why don't you come at national level? And then Archana is now in every place, wherever we are doing any type 1 meeting across the country. During my RSSDI, we have created a type 1 diabetes network across the country. We have done some more than 50 centers in India who are working in type 1 diabetes. We have done some online meeting with type 1 diabetes, and we created a type 1 diabetes network sort of thing that all those physicians, diabetologists, practicing physicians who have interest in type 1 diabetes, we created a sort of network. There was a support from CDIC. Long back, CDIC started in India with more than 15 centers. Me and Archana both are part of that CDIC. Then LFAC started supporting some more than 15 centers. They asked us, and we have asked them, these are the centers who are really working. And then we have created a suite registry in India. More than 50 centers again become partner, and at present, actively 15 centers are actively working in suite registry. I'm being a hub leader for Asia, and now in Asia we have more than 50 centers who are actively partner of this suite registry. JDRF had given some help, then other stakeholders like William J. Clinton Foundation, UNICEF, they all joined, and last year they all were the part of this TIEUP conclave program. The mission to build a positive ecosystem for type 1 diabetes care plan across the country, that each and every child, whether he is in rural area, everywhere, anywhere, he should get the best care. That was the primary mission of this TIEUP program. What are the basics of type 1 diabetes care? Is it only insulin? Do you think only insulin supply is okay for that is the basics of type 1 diabetes care? Many of the stakeholders or many of the people who are working in with government, or they feel that if you feel that type 1 diabetes care, they should be given free insulin. And some of the state government started giving also. The insulin is now available to some of the state government hospital. Is it only insulin which is sufficient? Or is it only about the control? We all know that type 1 diabetes, if they get aggressively good control, they will have less and less complications. So are we talking that basics of type 1 diabetes is only about the insulin, only about the control, or only about the preventing complication? I think there are many more things and many challenges in management of type 1 diabetes. It is not just the insulin, it's not just the control, or it's not just the preventing of the complication, because there is every day 24/7 they have so many issues, and many issues are responsible for them to have high and low sugar, and they have multiple issues all the time, and that's also required. And that is what the TIEUP have a vision and a mission, that we should improve the care for type 1 diabetes, not only just for providing them insulin or just to get a good control, but to take care of every aspect of type 1 diabetes care. We know the broad components of type 1 diabetes, and early diagnosis and awareness has to be done, access to quality care, a stable, affordable insulin, then monitoring and self-management, and there should be an education program for them. DCCT data, I'm sure any physician who is practicing today or any pediatrician in India, they all know that before 40 years, 1983, 1993, the data has been published that intensive control in diabetes will reduce the complication. We also know that intensively controlling diabetes will lead to a lot of hypoglycemia. So the people to achieve HbA1c of less than 7 was not easy, because it was very difficult to get at that time with those type of insulin available, and the hypo risk was very, very high, but still they were trying to do it, and they have proved that intensive control will definitely reduce the complication. In India, it's really a disproportionate medical burden of type 1 diabetes. It's very demanding in terms of medical attention. It is very demanding for the patient and family to cope. It's very demanding for doctors also. They are very, very they find it's very difficult for them to take care of type 1 diabetes. It occurs in when people are young, so it depends on the parents for their education also. More years of type 1 diabetes, major lifestyle changes, complicated regimes, and then they develop a lot of complication, acute complication like hypoglycemia or diabetic complication. If they are not controlled for a long period of time, they develop a lot of chronic complication also. In developing countries like India, as already Partha talked, that we are the fastest developing, or we have highest GDP, more GDP than UK, but still we are in developing phase, and we have a poor infrastructure, and there is a low ratio of public to private spending, largely out of pocket expenses, and that is also a challenge. And public health system are primarily geared to handle acute problems like infections and trauma. When we are talking to the government hospital, medical college to start a diabetes clinic or a type 1 dedicated clinic, they feel that yes, we have the doctors, but it's very difficult for us to, a dedicated team to only for taking care of type 1 diabetes or type 2 diabetes, because primarily are geared up for infections and trauma, which is again a large problem for our country. This paper, which has been written long back, before 15 years, Archana, myself, Dr. K.M. Prasanna Kumar, when we have started CDIC center across the country. And whatever the scenario was there at that point of time, still in last 15, 20 years, we had tried to change a lot of things in India, but still the scenario in India is not great. Still people are on premix insulin, they are developing a lot of complication. And that was the type 1 index paper had come before 2 years. And Partha had already talked about it, that those who have life expectancy of a person living with type 1 diabetes in India is only 34 years, and which is almost comparable with Sudan. And I find that even it is lesser than Sri Lanka. If someone develops type 1 diabetes in Sri Lanka, he is going to survive for at the age of 39. And in India, it is only for 34. Even for Morocco and Brazil are better than us. So we are comparing with almost like African countries, while if you see the people who are developing type 1 diabetes in UK or USA, they are going to have a normal life. So what we should do? Managing type 1 diabetes means they require at least 4 times insulin injection, self-monitoring of blood glucose, education, counseling, regular follow-up. If we do these few things, which is very, very important, and I think in last 15 years, whatever we have done, many of us started using the basal bolus, self-monitoring of blood glucose, which has become a part of their routine testing more than 3-4 times. We educate them. Its education is a continuous process. They have to do the correction doses regularly and a very regular follow-up to prevent comorbidities and complications. But this is only with some of the tertiary care centers, and across the country we may not have more than 20 or 25 such centers whose patients, who are more than 100 patients type 1 diabetes, who are managing their HbA1c less than 8 or 8.5. Most of the time it is the HbA1c of these patients are around 8.5 or 9, which is not being controlled by tertiary care specialist. So our basics is enough. I don't think the mission of our tie-up is not just to give the basics. We can do that. Every child with type 1 diabetes in India deserves to thrive in their life. And that is what our mission for tie-up. Tie-up care is, India is primarily concentrated on tertiary care, as I told you, but we have to have awareness has to be increased. We want that early diagnosis. The treatment and initial management should be planned accordingly, and living with type 1 diabetes for a long period of time with less stigma and more counseling and more knowledge about it. That is what our vision for this. Despite multiple advancements, there are many barriers to live with type 1 diabetes in our country. And I always request all those young physicians, all those pediatricians, all those physicians practicing diabetologists, that they should increase the awareness at the community level. Because still the community, they don't understand the type 1 diabetes. They still understand the type 2 diabetes. The poor understanding about the childhood diabetes, that's really very, very poor and weak healthcare system. We don't have the system by which that each and every type 1, whether it's a child or young adult, is getting really good care for these patients. We have to strengthen our system. We have to standardize guidelines. We have to capacity building. That's a what's the plan of RSSDA, that's the plan of EPI, that's the plan of tie-up, that improving care. It means you have to increase the number of healthcare physicians who are really interested to take care of diabetes, and particularly type 1 diabetes care. Improving the access to the commodities, to the drugs like the insulin, glucose meter, the strips, and we have to strengthen the follow-up. That's most important thing, and we have to enable the education and support system for everyone. This thing we all know from the diseasity that it is really very difficult for the patients to achieve a tight glycemic control. And most of the physicians, what they do, when a patient comes with an uncontrolled diabetes, just to slightly increase the dose of insulin, either 1 or 2 units here or there. And that's not the intensive treatment. Intensive diabetes treatment is just not more insulin. They require more education. That is what the intensive diabetes treatment means. If some patient comes with a 9.5 HbA1c, that does not mean that person is not developing hypoglycemia in between. And by increasing the dose here or there, rather you are increasing the risk of hypoglycemia, not achieving a tight glycemic control. So the patients who have more uncontrolled diabetes requires more education rather than just increasing the insulin. That should not happen blindly by physicians, by pediatricians, by diabetologists, endocrinologists, and that's very, very important. We have to build a basic care coalition. we all healthcare professionals are committed to work together along with type 1 diabetes communities or foundations in India, all type 1 diabetes foundation through a coalition that advocates the government. We are trying already since last 5 years. We had met health minister, we had given the white paper, we talked them. We are trying with the local state government, like Sujoy had done in West Bengal. We had tried with Gujarat government also. And our aim is at least try to achieve a glycemic control less than 8. Yes, definitely lesser is the better. 7 is more good, but still those who are on basal bolus and with the self-monitoring of blood glucose, even if we get less than 8, they will have better quality of life. We should increase that, only what they are having, the life of 34 years, at least they should have another 35 years plus healthy life years at the cost of maybe 75 cents per day. That is what type 1 index paper is saying, that if we put all the patients on self-monitoring per day with 4 to 6 times with the correction doses, with 4 times or 5 times insulin, probably it will increase the cost per day, but it will not increase so much cost. But in compared to that, the life which they are going to have is much more. The reduced hospitalization and complication costs, and that's what our mission is, that we don't want our patients. And next, immediately, our mission for 2025, immediate mission is that across the country, all those doctors who are treating or taking care of type 1 diabetes, they all should put them on a basal bolus therapy. They all should ask them for more self-monitoring of blood glucose level. And down the line, maybe in 2030, we may say that, yes, across the country now, average A1C of our patient is less than 8 or 8.5. We are now improving as far as their healthy life years, which we are giving to them, and reduce hospitalization, particularly like decay, and reduce complication cost also. But our mission is not just ending here by just providing them a self-monitoring of blood glucose or giving them a free insulin. Our mission is technology for all, because we know that unless we do a continuous glucose monitoring for everyone, just by giving SMBG or by basal bolus therapy, still you can't achieve HbA1c of less than 7. That is what DCCT trial also. A lot of hypoglycemia was there. And even after 25 years, the 1983 they started. In 2008, the similar type of patients with JDRF supported a continuous glucose monitoring. The severe hypo reduced from 62 to 20 per 100 patients here. And they were achieving the HbA1c from mean A1C of 7.6 to 7.1. So you can understand by just changing from self-monitoring of blood glucose to continuous glucose monitoring. And that's what I was very much impressed when Partha was working hard in 2015 to 2020, that each and every type 1 in UK should be on continuous glucose monitoring. Why they should be on self-monitoring of blood glucose? And this is the data which shows that there can be a significant improvement in HbA1c with lesser risk of hypoglycemia if we put our patients on a continuous glucose monitoring. This was a consensus which was in 2017. I was the part of it, only Asian for the part of this international consensus on use of continuous glucose monitoring, that each and every type 1 and those who are on insulin therapy should be on continuous glucose monitoring. Even at that time, we were not using so many patients on CGM, but still I was part of this 2017 CGM consensus. And then in 2019, a time in range, and I was a part of it. And then it has completely changed the concept, that we were chasing the HbA1c, and now we are thinking of time in range. No more talking about the HbA1c. We have to think of A1c, not A1c. We have to think of time in range. And that's what we want. Most of our type 1 diabetic patients, they should achieve more than 70% of the time in range. Yes, definitely elderly, more risk of hypoglycemia, frail patient, still they should have more than 50%, but more than 70%, that is what we want for them. And less hypoglycemia, less than 5%, it is not accepted. If they have more hypoglycemia, we have to change the therapy, and they should be on continuous glucose monitoring. And then Partha started again that now no more only on CGM, because alone CGM is not going to work out, because if people putting on CGM, only 30% of the patients will achieve a optimal A1C target, unless we do other the insulin pump therapy, a hybrid closed loop system, we are not going to achieve the tight glycemic control, because just putting the CGM, yes, they can have a better glycemic control, less hypoglycemia, but still hypoglycemia risk is very high, and they will not achieve the optimal glycemic control. And that they started in last 2-3 years that everyone should be on insulin pump, and last year they're successful, and now UK government had started putting their patients on type 1 diabetes this year only, that they can be on insulin pump therapy. India is also a country of paradox. I always say that yes, we have few poor patients, we have many poor patients, and we have few rich patients also. We have people who are very poor. You think of them for a basic care. You think of them for a basal bolus therapy, giving them self-monitoring of blood glucose, trying to give them free insulin, free glucose meter. Government should provide them. There should be a dedicated type 1 clinic. At least they should achieve the HbA1c of less than 8. They should get less and less hypoglycemia. That all should happen. But 20-30% of the patient, and those who are the part of this fastest growing economy of India, those who can afford, why can't they be on the advanced hybrid closed loop system, which is available? It is available even before USA to India. And this is the data that if a patient is only on multiple daily insulin injection and with blood glucose monitoring, only your time in range is 45%. This is the average A1C, as I told you, 8 or 8.5. And if your patient who is doing 4 to 6 times self-monitoring of blood glucose with the patient who is on multiple daily insulin injection, you will not find these patients more than 50% of the time they will in time in range. But even if you put these patients on a continuous glucose monitoring, it may improve slightly. If you give them a sensor augmented insulin pump, probably their time in range will be around 60-63%. But if you use hybrid closed loop system, it will be 70% above. That is 670G or 770G, which was not available to our country. But then if you put them on advanced hybrid closed loop system, which is available to us, which is hybrid closed loop system 780G, you will able to achieve more than 70 or 75% of the time they are in time in range. And this is the India data. We have published this data with our initial 219 patients. These were the 10 centers who have initially put patients on the advanced hybrid closed loop system. 219 patients, which was comparable with the all over the world. If you can see from other parts of the world also, and India had also shown with these 219 patients, our time in range was more than 75% of the time they were in time in range. So that's without risk of any hypoglycemia. Here you can see the hypo is almost negligible. So those who can afford, at least they should be on. Now we have more than 1,000 patients in India who are on advanced hybrid system. Those who can't afford, we can do it yourself in artificial pancreas, DIY. This is Jyoti Dev and myself and Jez and many in India. They started already putting the patients on a older insulin pump with this continuous glucose monitoring, and they can do DIY. And that's what also, at least it will help them to have achieved a better time in range or a better glycemic control, which is also cost effective for many of our patients. So our mission is to have our own registry. We can't just depend on sweet registry. We can't just depend only on some other registry internationally, but we have to have our own registry. Already Partha had told that we should have our own data to say that we have these many number of patients. This is the status. So we need our own registry. This paper, again, we have written long back that along with Dr. Anju Virmani and Sanjay Kalra, that we need our own registry, and that registry is very much required for our. We should have our own guideline. Even we are the part of SPAD guidelines from 2014. Myself and many of us, the Anju Virmani and many of us are part of the guidelines since last 2014. In 2018, we have done SPAD also in India. But our mission for the tie-up is to have our own guidelines, that what we should do, the minimal care, and what the care which we should give to those who have those who can afford for our patients. Now we always talk about the disparity. In India, yes, there is a definite disparities there. Those who are in an urban area, those who are going in a tertiary care, those who can afford, they will get the best care. But this is not only in India. Even if you see, this is the diabetes care in 2023. Even in US also, the disparity is there. They're using the continuous glucose monitoring, using the between children with type 1 diabetes living in urban and rural area. So disparity will not be there, that I don't think. But still, this year for tie-up, we had thought of that instead of our mission is our goal is that we should have less and less disparity amongst the people with type 1 diabetes, whether they are in urban or they are rural area, whether they are going with the tertiary care, but still the disparities will be there, and this is there across the world, even any part of the world. So peer support group is really very important. JS is working very hard for some of the centers, but many foundations in India, they are really working. Mehak is also doing very hard work for these many of the type 1 children who are actually now have their own foundations, and they all are working. This was the picture we have taken before 6 years in Ahmedabad, and these all of them are working very hard to create more peer support, and they have started foundations, and many children are also they go, they educate, they do the camps, and they try to educate these children on a regular basis. We have also done one up challenge in 2015 in Greece. One of our type 1 child from my center had gone for this Greece, and then we have created our own first type 1 challenge in India also in one up, and then again with Archana we have done one more 2 more program in Maharashtra, again 1 more in Abu. So we have done these support program. This is the last year, the first time a tie-up conclave which we have done in 2023 at Aurangabad. Again, central part of India, Archana have done it, and almost every part of the country we have invited those who are interested in type 1, not only the type 1 specialists, doctors, endocrinologists, pediatricians, but also those foundation. And we were having ID of President-elect along with us, Partha, and even LFSC chair, General Manager Dr. Graham was also there with us. Our mission is a physically, psychosocially a healthy citizen of India with type 1 diabetes. And that is what our mission is. If they develop type 1 diabetes, on an average, they will lose 45 years of those healthy layers. And that is not our mission. That which we want to change. After 10 years, 1 more paper of type 1 index should come, and we should be shown with those top 5 countries that we are also having a type 1 who is developing in our country below the age of 10 will have their survival up to the age of 70, not like only up to the age of 34 and compare with Sri Lanka or Sudan. That should not happen. So it's a high time to make type 1 diabetes care more affordable, definitely more approachable, more accessible. And that is what we want. We want that every child in our country should get the best possible treatment across the country, wherever he is, to have a normal, a very healthy, a long life without complication. And those who can afford latest technology, they should use it. So in 2025, at least we want that everyone in India should be on basal bolus therapy. By 2030, all of them should be on self-monitoring more frequently, and 50% of them, at least those who can afford, or the government should supply them in continuous glucose monitoring, and 10 to 20% of them, those who can afford, they should be on an advanced hybrid closed loop system. So we have minimal care by 2025 for everyone. By 2030, more technology use, more number of patients should be there. But our vision is by 2047, when India will be celebrating 100 years of independence, I believe that by that time, the government should provide every type 1, like what UK had started giving every type 1 a advanced hybrid closed loop system. By the 2047, we should all have, all children in India, all type 1 adults or children should be given insulin pump therapy, and that is what a cure for type 1 diabetes. Something like that, at least they can have a normal life. With this vision, I once again thank you, Archana, thank you, Partha, and all those who are involved, Amit Day, Rutul, Myra, Mahek, everyone, Riddhi, for involving me and giving me this opportunity. Thank you very much.
Thank you so much, sir. It was an inspiring and passionate talk, as you can see in the chat. And as you said, the life expectancy is around 34 years. And with technology, we can win 25 more years to that. And I'm hopeful that with the mission and vision of TIEUP, we'll be able to change those numbers one day. So thank you again. And with that, I invite the panelists. And we have Dr. Rutul Goklani, who is the co-founder of Empower Team. And we have 2 inspiring patient advocates with us, Ms. Riddhi Modi from Mumbai. She's the lead coordinator for Empower, and the another lead coordinator, Ms. Mahek Dhingra from Delhi. Please, can I have yours? Also, we have the senior endocrinologist, Anju Virwani ma'am, and I request ma'am to join as a panelist, ma'am.
Also, we have Dr. G.D. Ramchandani, who is a senior diabetologist from Utah. Hello.
Anju ma'am, if you can turn on your camera, I'll be able to put you as one of the panelists. GD sir is there. Also, if we can call Harsh Kohli, he is one of the very active worker on type 1. Harsh Bhaiya, if you can turn on the camera.
Yeah, we actually have a few leads from the type 1 advocacy groups, and we would like to introduce them. Whoever can join and share your camera screen on. We have, I think, Prashant. We have Jyotsna.
Yeah, Jyotsna. Yes. Chavi is also there, right?
Lakshmi is there. Shuchi ma'am is there. So whoever would like to join, please just put on your cameras. And I think we can proceed as and when people will join in. Archana ma'am, maybe you can just share a bit, because you've been such an integral part of TIEUP as well as the advocacy groups. We would like to see what you would have to share with us.
Do you want to know about TIEUP? Are you asking about the conference?
Yeah, like maybe, yeah. And okay. We have Meenal ma'am also. So eventually we'll just...
Right. So I think when we did the first one, it was the first time that we were thinking of having a very comprehensive kind of a meeting where a topic was relevant for clinicians, for educators and nutritionists, as well as community living with type 1 diabetes. So very interesting. Initially, the thought was, what should be the level of science? Initially, what was usually thought that the patient community, usually we have a different level. But then we actually, when we were, making the curriculum and deciding what we're going to talk about, we realized it's absolutely not the same when it comes to type 1 diabetes. And the science, as well as the nitty-gritties, and especially the practical aspects. And we actually decided that we are now going to learn from the type 1 community. And that's why we had lots of workshops then, which were led by people living with diabetes. And as a result, I think a lot of clinicians came back and gave me feedback. This was the first time they had a first-hand experience of, what a difference it made, or such empowered community. So I think the first experiment or first desire that came true in December is something we really want to continue and have the triad very, very strongly nourishing each other. I think it's a very mutual nourishment, very mutual encouragement and learning for all of us.
Yeah, I think it was very important that Banshi sir highlighted that, right now we are at a stage where coalition and collaboration is very important. And we have so many foundations who are doing exceptional work. They are all geographically located in different parts of India, each one doing their best with their team of whatever they can address. Some of them are excelling with education and awareness. Some of them are working fantastically well with their support groups, their team of volunteers. Some of them are more engaged with policy matters, working for school children, whether it's close interaction with ISPE groups or RSSDI. So each one is doing fantastic work. Now is the right time, as last year TIEUP has given us a fantastic opportunity and a platform. So what we would like to take the opportunity today is to firstly thank TIEUP for this platform so that we can all come together. And secondly, for the community to think about it, that this is the right time to collaborate, because we can learn from the best practices that each of us is following. Some of us are located in a situation or in a geographical city where we can help in different ways. So each one can continue to do their good work, but we have to learn from the best practices of each other, time and again meet, collaborate, discuss, and see how we can take this to the next level. So we have had enough discussions and enough education related camps, or we have been, engaging in policy matters, working with different stakeholders. But now is the time to collaborate and work with our empowering HCPs. So thank you, Empower T1D as well as TIEUP, for having this platform ready for us. We feel safe. We feel extremely hopeful that the future of type 1 diabetes is going to change very soon in India. And, mentors and leaders like Partha sir, who is so extremely approachable. Like he said, Fir bhi dil hai Hindustani, we feel he's just a Zoom call or a message away. He's always there for us and mentoring us in innumerable ways. With his minimum slide and maximum impact, we feel we have a great mentor here. And Archana ma'am and Banshi sir, all the other doctors with Empower. So this is my personal urge to all the foundations that let's take this opportunity, come together and think about how we can make the best of the next few months to come up with creative ideas on engaging the foundations with TIEUP, so that we can make TIEUP 2024 a huge success in terms of creating more impact. Like there will be learning, there will be discussions, but what are the takeaways going to be? And I know that, like Banshi sir highlighted, there is an urban-rural divide. We always feel that, the rural children are less privileged. But what are we doing, all of us who have the privilege? Are we doing enough? This is a time to think about it. Are we all doing enough? Are we doing our best? And what is it that each of us can bring to the table? So I'll hand over to the rest of the speakers.
Thank
Ma'am,
you,
could
Vicky.
you get Dr. Meenal in the panel as well?
Yeah.
Sorry. Yes, Dr.
Yes.
Please go ahead.
No, ma'am. Please, Meenal ma'am, would you like to say something about this collaboration?
Yes, of course. Very good evening. And yes, we have all been listening to Dr. Archana, Dr. Bansi, Dr. Partha. TIEUP and empower, the two very strong words in themselves. Empower the TIEUP. It's time to empower the TIEUP, I believe. So I invite you all, because the next follow-up session, the live telecast of TIEUP, how we are doing, assessing, laying down the future plans, will be in December 24 at Jaipur. So I will be very happy to rather have a roadmap from all of you and guide me so that how can we take it further. We will be having all the NGOs working, all the people with diabetes, all the legends working in diabetes, type 1 diabetes, teachers from whom we can still learn more, and of course, people living with diabetes who are the real teachers. We think we are teaching them, but I think it's every time they teach us something before they leave our chambers. So that is what I learned today itself. I had a few new type 1 patients, so I really learned some new things from them. So it's really a long journey still. We are just the beginners. We have started walking. Yes, we have started walking at least. That's very nice. But we still have a long way to go. And as Riddhi said, the collaboration, collision, it's the right time. Dr. Bansi, you are here. My personal request will be, when you are in Jaipur, give us the real roadmap. Any practitioner coming across, maybe we are not having foundations, maybe we are not having a huge burden to label ourselves as exclusive type 1 practitioners. But still the data is so distributed that all of us once in a while come across some new type 1 patient. And at that point of time, as a clinician, what are the hand-holding places where we can look forward to? The patient is rural. I got a patient rural, no support, no financial backup. Then we talk of CGMS, we talk of pumps, but please give us a roadmap where we can dial, where we can lead them to, where we can look forward to, and how we can actually handhold that patient to the target of HbA1c 7 or TIR 70%. So please give us a real roadmap so that we can all learn from you further. That will be my request to Dr. Bansi, Dr. Partha, Dr. Archana, and all the legends here.
Thank you very much, ma'am. And we are really thankful to Bansi sir, Archana ma'am, and Partha. As first time, whenever I have gone to Bansi sir or Archana ma'am or anyone from our seniors with any proposal, first of all, they have never said no, that no, we can't do this. because TIEUP and Empower, they were different entity. And when our idea was to bring up all together, whether it is advocacy group or doctors group, and in Empower we have mainly our seniors, juniors, and TIEUP where it is completely a different forum. So thank you very much for the collaboration, and definitely in next few months when we are going to have many programs under the banner of TIEUP and Empower. So we clearly want the roadmap that exactly what we want to cover up when the minimal care to best of the best care that we want to provide. But yes, at least for my idea is to have at least for 3 to 6 months, we want to run one specific program, and that should cover each points, especially basic care that everyone should understand. And we should try to get more and more physicians, if it is possible, as Minal ma'am has rightly said. Every doctor, once or twice or 5 times in life, they come across type 1 patient, and they don't know exactly how to do it. And they can't, that patient, they don't want to lose. Sometimes and patient even does not want to go to any other physician or pediatrician or pediatric endocrinologist, or they can't afford it, or it is far away place. So we want more pediatricians and physicians to get enrolled in this Empower and TIEUP programs, if we can do it.
So, Rutul, I just want to answer here, as Minal had very right question that what they should do if someone gets a patient. So, like everyone can't become like Archana, who is working 24/7 only for type 1. But I always request that any physician or any diabetologist who is really interested in type 1, at least for one day they can become Archana. At least Saturday they can start a dedicated type 1 clinic. So that's number one can do, and that's doable. I mean, one can do is a charity, as a part of charity, if they are really interested in type 1. The second, if as a physician, if I am not interested in type 1 care, I think that is what the structured referral system, that if I am not interested, I should find that. The second thing, what me and Archana had decided, that across the country, we had already talking to all the foundation, but all big cities and even tier 2 city or tier 3 city, we have identified some of the foundation. Suppose if I can't hold the patient, or as a hand holding, or how to get the free insulin, how to get the glucose meter, how to get the CGM, at least I can get a foundation member name or his number, then they can guide us. The third thing, from the government level, I can tell you, almost all state government started providing free insulin. So free insulin is not a major problem. It is the education which is a major problem. So I mean, you don't worry about that your child will not get the free insulin. What he will not get, probably glucose meter and strip may not get. And for that, I can tell, even not from the RSSDI, Diabetes India, Type 1 Foundation, or you can tell me anything, we can arrange glucose meter and strips across the country for every type of child. By whatever the way, how we will do, that's the next program. But the insulin one can get. What child is not going to get, or the parents are not going to get, is education. And that's the duty of doctors. If you have really interest in diabetes only, then you should educate type 1 children, type 1 adults, their parents, their caregivers, and that is the duty of the doctor. If they can't do every day, as I told you, like Archana is doing, you can do once in a week. You can do every Saturday. You can run a Saturday type 1 clinic in your chamber. That is what easily doable. So this much we can do. We can tie up with the foundations across the country. We can do one more thing. We can educate other doctors. Like suppose you are there and you want to educate the pediatrician. You want to go and medical college and teach the medical students, maybe MD second year or MD pediatrics, those who are doing their residency. In last 15 years, one thing which we have done is like whether it is API, whether it is RSSDI, whether it is a regional meeting, whether it is a state meeting, whether it is a Diabetes India meeting across the country now, in a year, more than 15 meetings are there. And every meeting you will find there is a type 1 diabetes symposia, there is a dedicated workshop, there is a pump workshop, there is a CGM workshop. So we are trying to educate the doctors across the country. Now it is the time that we should make a roadmap, as Meenal had said very rightly. Now the last thing for the meeting at Jaipur, first my request is that everyone should, who is interested in type 1, they should come without getting any expectation that what I am going to get in those 3 days. I know everything about diabetes. That's not, because it is an advocacy also. If we come together, that itself is more important, rather than forget that what is your what you are going to get, whether you will be given a talk, whether you will be asked for chairing a session. No, and you have to come on your own. That should be our primary aim. We are not dependent on any industry. That is the first and foremost thing we all should do. More than 200 doctors and associates and the foundations and the patient, they should register on their own, and they should plan that how they should reach for this meeting. That is the first thing which we should do. And we should take the oath that we are going to do, like each one of us, for the next year, we are going to do for 100 patients, doctors, or the community worker, healthcare professional, we have to educate in next 1 year. If we take this oath, we take promise on ourselves, I am sure we can create a lot of difference in our country. So at least 200%, out of them 100 or 150 maybe the doctor, or another 100 or 150 maybe the foundation people, or the people who are running the foundation. If we come together, I am sure we can change the picture of India.
Welcome, Anju ma'am.
Thank you,
Anju
sir.
Nani ma'am is here.
मैडम के नीचे हर्ष कोहली कैसे लिखा हुआ है?
I think she's. Ma'am, you're on mute.
मैडम अनम्यूट करिए.
Yes, ma'am. We would love to hear you.
अभी भी अनम्यूट नहीं किया आपने, वापस म्यूट कर दिया.
It's.
Yes, madam.
I was saying उसके लिंक से ज्वाइन किया, मेरे को लिंक नहीं मिल रहा था.
अच्छा, इसलिए नाम आपका.
And we would love to hear
बोलिए
your
मैडम.
thoughts on collaborations of the community and the healthcare providers, and how do you see that future and the missing links?
अभी तो let me listen.
Okay. Wonderful. So I
There's so
will
much
take this
interesting and
opportunity to
much
ask
informative, discussions are going on.
Thank you. I'll take this opportunity to ask the young type 1 leads present here to tell us their viewpoint. Jyotsna, I can see Sumit is there, Lakshmi is there, Harsh is there. Could you, give your comments on what are your perspectives on what you expect from healthcare provider collaborations, maybe from the TIEUP conference, from the experience you had last year, and what you would like to experience this year? Sumit.
Thank you everyone. Last time जैसे टाई अप कॉन्क्लेव जो किया था वो एकदम इट वाज ट्रेमेंडस, बट अभी और भी ज़्यादा इंटरेक्टिव करना है या फिर ज़्यादा टाइप 1 को इन्वॉल्व करना है, तो एक छोटा सा सजेशन है कि और टाइप 1 सेंट्रिक किया जाए, प्लस जो कम्युनिटी जो रन करते हैं वो तो आते ही, साथ साथ में कोई एक्स्ट्रा एक दो हर एक कम्युनिटी से दो तीन टाइप 1 को भी बुलाया जाए तो थोड़ा अच्छा और भी अच्छा रहेगा. ऐसा एक छोटा सा सुझाव है.
Right.
Definitely.
And every state.
At least we can start. Yeah.
Every state needs to be covered. I totally agree. Yes, Sumit. Continue, please. Sorry.
बस ये छोटा सोचा तो बाकी दूसरे को जा सकते हैं.
Yeah, we have Jyotsna. Yeah, she wants to say.
So I would like to add, first of all, I'm grateful that the tie-up, I think it's my loss that I wasn't there in person. But, I got to know about the tie-up conference from my diabetes, Riddhi, and everyone about how amazing it was. And it was, I think, first conference where so much attention was given to type 1 advocates and also organizations. And the good thing was, which I absolutely loved, that so many organizations and also advocates who are not necessarily part of any organization were also invited to be a voice and to share their opinions, and which was, I think, wonderful. And I would like that to be followed in these subsequent tie-ups as well, so that more and more people get chance to, because it will also help them as advocates, with their confidence, and they'll also get a chance to work with other people and learn more. So I think that should continue. Apart from that, what I think should also be included is that I think the collaboration wise, we are improving a lot. This year, I think it has been an amazing year with, we had a conference at Bhopal, which was wonderful, where so many clinicians and even the government and the organizations all came together to talk about the necessities and the standard of care that is required for type 1 diabetes in India. And I think more and more such collaborations would also aid us to understand what is missing and how we can be of support to healthcare providers, because the work that they're doing and the work the healthcare providers are doing is absolutely tremendous. And if both of that gets connected in power, we can absolutely achieve wonderful results and outcomes that we wish for. So I wish that, we can have a platform where not only the advocates who are currently working get empowered more with the help and support of healthcare providers, but also give chance to new people to become advocates and think about advocacy as something very, very crucial and important, and not just like a responsibility that they do by the privilege of, living with this condition. So that would be my 2 cents on it.
Thank you, Jyotsna. We have Prashant. Prashant, do you want to add something or?
Yeah. So I think one of the major points, I think everything has been discussed. But one major point, as Jyotsna said, like in the Bhopal meeting where we had clinicians and we told them like, the 4-point strategy and all that. So I think from the HCPs, we can get more such events in other cities as well, get the clinicians, tell them how the type 1 scene is there or what the community wants from them. So getting the clinicians together and telling them, okay, basal bolus and other things to follow will be a great step, because for any type 1, the first point of contact is the doctor. So getting the clinicians together is something great. And also like empowering type 1 community support groups. So tie-up only last year, even I discovered so many groups which have been working for 10, 15, 20 years, but we weren't aware of them. So thanks to Dr. Archana and Ridi for getting them together. And I think this year we need to get in more groups, or at least create from states where there are no such groups. So a collaboration of getting all the communities together and working with the doctors will go a long way. Thank you.
So I just wanted to add, in Bhopal, Prashant and Jyotsna were there, and the entire doctor community, they were like, who are those two? And I said, okay, these are people living with type 1. They have type 1 diabetes. They look so fantastic. I mean, the doctors were surprised, which meant that they had a kind of a thought process that this is not what a person with T1D looks like. So it's that important. I mean, no amount of theory talks that day, which we could have given, would have made the impact. What the impact happened when Prashant and Jyotsna walked on stage and they talked about themselves. So, this is really, really important at every level.
Ma'am, can I add?
Yes, Lakshmi, of course.
Yeah. So the first thing is that, I mean, from last 5-6 years, T1s are, all T1s are coming together and numbers are increasing. Thanks to all the advocates, doctors, and all the healthcare providers. So, Prashant always says that because numbers are increasing, we need more people, and especially from small towns and rural areas, to be trained how to volunteer, how to educate nearest T1s in their area. So we only have ideal course, ISPE ideal, and few like 1 or 2 diabetes educator course. And that too in English alone. So if possible, if doctors can help us in creating more diabetes educator courses so that we can train more T1s, that is one thing. And any other ways to address, because now, I mean, earlier we were able to take calls individually and help them. Now the numbers are really big. So what are the methods to help the community when the numbers are growing? Thank you.
I think this is something we will
So-
all work on, and that is where this collaboration is going to help. Let's all,
So-
pool in our ideas, thoughts. Let's keep writing. Let's not stop. And something will definitely come out of this. No one has all the solutions today, but we are all moving one
So-
step at a time in the right direction. So we'll
So-
work on this
so-
all together.
So the number definitely is
Yes.
exponentially increasing. So definitely we need more and more advocacy groups and peer support groups. And definitely we need to train more and more people. And as rightly said by Lakshmi, that we need every guidelines or educators who can help in their own language so that we can have more education. Now, anyone wants to add something?
Mehak, I invite Mehak
Yeah.
to share her thoughts.
Just before I share, there are some seniors I would like to give them the opportunity before
Yes,
I
please.
share. Ramchandani sir has raised his hand. I'll bring him on spotlight, and then we have Harsh Kohli. He's way senior to me in this. I would like to give him the opportunity first before I share. Just bringing Ramchandani sir on spotlight.
Thank you, ma'am. First of all, we are excited, especially Meenal and me are excited to welcome you all in the Rajasthan in December. And for that, Meenal is working so hard, and we have done 2 meetings there also. And the idea of Dr. Ashna and Dr. Banshi is excellent. I heard everything, and definitely we'll add something new. My suggestion, I think one person from every district should be trained, whether it could be a educator, he could be a patient, the family member, or a doctor, or we can take help from the district coordinators project of RSSDI. In RSSDI, we formed every one person from every district. He was the coordinator. So education is the most important part. For the education in small area, Tier 2, Tier 3 cities, if one person is trained, that and like Bansi told that if you cannot treat, you can refer to that patient to the particular center or particular person that he will educate you. Education is more important. And insulins we are getting from the government of India, rest we are providing. So that we can plan that every district should be covered, and if, how we can plan that is my suggestion, ma'am.
Thank you, sir, for sharing it. Anju ma'am wants to add something. Anju ma'am?
Yes, please. I guess she is already added by you. And
She wants to share something, ma'am. Yeah.
Ma'am,
Yes,
as I
Anju.
said, Dr. Banshi and Dr. Archana are at the core of a very strong group. We're talking about CGMS for everyone, but as I see it, it's very tragic that CGMS is actually going out of our reach in the last few months. Instead of being able to get a cheaper Libre Pro, we are now being saddled with the company forcing us to accept only Libre. So a lot of people who will not be able to afford this will be thrown out into SMBG. Can we use the current political clout we have for pressurizing the company to continue providing this Libre Pro? It's not as if they're not manufacturing it, they're clearly planning to stop manufacturing it, which would be a big loss in terms of control. We have political clout at the moment. Banshi, and you are very powerful in the government circles right now. Can we force them to do something, both in terms of price control and availability?
I think this is something Dr. Bansi only can answer. But point is absolutely right. We are also extremely troubled with that fact. What we were able to do with Libre Pro, and now it's tough.
May I add something?
And there's a new CGMS which is coming as well. Yes, Rutul, you were saying.
Yeah, ma'am, actually they are telling this thing since last 4 years that they are stopping the manufacturing, but I don't think they are doing it in near future, at least for 1 or 2 years. And by that, I guess we'll get more and more sensors from different companies with good accuracy and real-time monitoring. And then let's hope for the best as we are, as in last BTechCon, we have come across many other companies who are coming up with real answers.
I think competition will make
Yes,
it happen.
but Rutul, I think as I see, it will take another 2 or 3 years for that gap to be filled, which is a long time in somebody's lifetime. 2 or 3 years of bad control can really demotivate. And right now they have the production. They're just being bloody minded and business minded about it. In the past, our government has forced people to take decisions which are in the interests of people, not just of the industry. And nobody's asking the industry to make a loss, just to be less money minded. Can we use our political heft at the moment?
So definitely we need to ask this question to Banshi sir, and he actually just left because he is not in India right now. So definitely we'll ask this question to him, and we'll try to find the solution. But I guess it is that Freestyle Libre Pro even is they are manufacturing it in not in India. So it's difficult to force them even for Libre Pro to continue the manufacturing, I guess. Thank you, ma'am.
Can you add some? Can you add something regarding this?
Yeah.
Sorry.
Yes, please.
Yeah. So I from since long back मुझे एक थॉट आ रहा था कि अर्लियर जो पेसमेकर का स्टैंड था वो हम खुद इंडिया में प्रोड्यूस नहीं कर रहे थे. देन नाउ DRDO ने जो बनाया उसके बाद में जो स्टैंड है वो दो वे चीपर बन गया है. तो कैन वी रिक्वेस्ट सर गवर्नमेंट के जो स्टैंड जो पहले नहीं बनता कभी वो DRDO बना रहा है, तो सिमिलरली सेंसर क्यों नहीं बना सकते? वी एज ए इंडियन टेक एक्सपर्ट्स अराउंड द वर्ल्ड, तो वो क्यों नहीं बना सकते? तो ऐसा कुछ रिक्वेस्ट कर सकते, ऐसा कुछ सब एडवोकेट करके कर सकते हैं, तो वो ज़्यादा चीपर होगा हमारे लिए.
Wants to comment on that?
Definitely,
Yes.
Sumit. Thank you so much for that thought. What Anju ma'am said was that by the time we get the other sensor or the other production, we will be losing crucial time. However, what Sumit said also is important, that we should start, because till the time we have CGMs, we can start right now to think in that direction, which is very important. Thank you, Sumit, and thank you, Anju ma'am, for at least feeding that thought in our minds, and we can think in that direction now. It is very important. And with that, I want to invite Harsh Bhaiya. He was sharing some points in the chat box. Harsh Bhaiya, if you're there and you want to share something.
Yeah, hi, good evening, and good evening to all the seniors. Thank you, Mac. TIEUP was very successful. I remember working with Riddhi during the initial days, and she was like looking for people to invite. So I requested at that time that we need to move beyond the metro cities. So I remember Riddhi reached out to people from various parts of the country because of less time, those people could not join. So maybe if you want more people from various parts of the country, like you were just Dr. Ramchandani was saying that we need to teach people in every district, but before that we need to call them and tell them that yes, you are indeed important to the cause. So let's start that job early on. Let's start reaching out to them as early as possible so that they can block their calendars well in advance. So please let's do that. Another thing that we need to actively work on is GST reduction on insulin supplies, glucometers, and sensors. Insulin is 5%. I have been told by various people that 0% taxation GST can be counterproductive. I'm not a technical guy, but something is there. So we can push for a lower, maybe 2.5% GST rates on all type 1 diabetes supplies, which includes sensors, needles, glucometer strips. It's not only about insulin. So let's make a push about that. Together we've walked a lot together, and we can move a lot of things if we come together. Thank you.
Thank you, Harsh Bhaiya. Thank you for sharing this important point. And now I know we are already at the verge of ending this, but there are 2-3 people who want to share. So first we have Suvit. I'll make sure we don't exceed 10 minutes, but let's also hear them. They are all important to us. Suvit is the father of a 3-year-old type 1 who is pushing to bring technology in India. Though he is silently working alone, but I think this is opportunity where he can interact with you all. So I wanted to make sure that he speaks with you all. So Suvit, over to you.
Hi everyone. So there's been a lot of talk of educating people and getting the basics right to everyone. So my just 2 cents were that a lot of T1, there's a lot of stigma involved and there's a lot of underconfidence that I've seen in people who have type 1 diabetes. And if we can have gatherings and meets, say every 15 days or once a month, where many T1Ds are meeting, like I know Mehek conducts them, Hershey conducts them, and they keep learning from each other. They see, okay, what the other person is doing, how they're bolusing for certain things, or what particular technology they're using. That gives them a lot of confidence. Okay, if he can do it or she can do it, I can do it as well. So this is just from the ground root, we can actually start creating a lot of confidence in everyone that you need to do such things. And if they keep meeting with each other, they know we're not alone. So a lot of sense of togetherness that will come and the community might just grow. So if we can actually do it in a much official and organized way, having say meets whenever it's possible, once a month or twice a month, that will actually help every T1D, getting to know, okay, there's so many people who are affected with type 1 diabetes. Generally, they meet each other in online or maybe when they go and meet the doctor in the hospital or a clinic. But if there can be informal gatherings where everyone's meeting, say on a breakfast or out in a park in the morning, and just gel or just do yoga sessions, and if that's in a very structured and organized way throughout the country, if it can happen, that will really make sure everyone's together and growing together.
Thank you, Suvit, for sharing this. There are some other organizations who are doing meeting, but now it is time to move beyond the name of the organization and collaborate and do the meetings. Very important point you shared. Thank you so much. And with this, next we move to Dr. Suchi. After Dr. Suchi, we have Chavi, and then I will be sharing the vote of thanks for all the speakers. So over to Dr. Suchi.
Thank you, Mehek, and thank you, everyone. Thank you, Dr. Archana. Thank you, Dr. Bansi, Dr. Partha, everyone, Dr. Anju Vermani. Thank you so much. Look, things have changed. It's not that we all my friends, Prashant, Harji, all of you, look, things have changed. We have one time when the human insulin was 200 rupees. We will say that it doesn't matter. But at that time, 200 rupees while meant a lot. And after that, when it came into Essential Medicine Act, the prices have gone down from 200 to 125. There was a time when we started to organize people. Then people would not come, sometimes in fear that people will recognize that they are people with type 1 diabetes. Now we organize very easily. But yes, don't think that your effort is small or big. Don't think that you can't do. Whatever you can do, whatever as a person with type 1 diabetes doing, do it. Even telling, like if you're a school teacher, I always say, tell your other teachers that you have type 1 diabetes. But telling that also will make people aware that you can be successful with type 1 diabetes. So, and yes, collaboration is needed with healthcare professionals, with government, without doctors, we can't move ahead. So let's collaborate and let's keep on doing our efforts and let's keep on writing to the government. I would prefer that each one of us start writing whichever government, whichever thing that we need these things, because statistics would not become good if each and every child gets the good insulin, CGMS, and other things. That's all.
Thank you, Dr. Suchi. Thank you so much. A lot of people don't know, they consider you as a doctor. Please do tell them that you are living with type 1 from how long. It will help a lot of them to relate to you.
I've been living with type 1 since 1989.
So you are an inspiration to many of
many of you I can say, Mehak, you were not born at that time.
Definitely. Yes, I was not born at that time. Thank
That
you.
time
Thank
we didn't have we didn't have even glucometer at our place. I used to check by Benedict solution. So it's a I'm not going to talk about that history, but I mean things can work. And I still remember the day when insulin from 200, it used to cost, and it was 200 into 3 vials, that means 600. And the total expenditure was around 1,000. But that time, 1,000 means something like more than 15,000 today. At that time, your salaries were so less. My father was it was not so easy. So things have been better. So keep patting your back, but we have lots of to do. Lots means lots to do together.
Definitely. Thank you, Dr. Suchi, for sharing your points and your history. It is always inspiring to know where we are coming from and where we are going ahead. Thank you so much. Chavi, quickly, if you can share your points, and then we'll move to Dr. Meenal. Dr. Meenal wants to invite you all to Jaipur. So, Chavi, after you will hand it over to Dr. Meenal. Chavi?
Yeah. Hi. Hi, good evening, everyone, respected doctors and all my type 1 community members. So I totally agree with each and everyone's point. And my point is equally same what Sumit said, we have, shortage of sensors. Every time we get to know about the news. So why can't we start making sensors in India? If we could ask the pharmaceutical companies, or, what exactly it's in Make in India. So I guess it would be, more accessible, and more of type 1s would be able to use CGM, and definitely it will have a great impact on the health and the diabetes management of every type 1, or till to all those who can be, जिन तक access पहुंच पाएगा इस चीज का. So very first thing is this. Secondly, from the last conference we had in Aurangabad, so the thing which I like the most is the workshops, which I would definitely want. And I guess everyone will agree with me, in all our upcoming conferences, workshop would be a major part in learning, and wo honi chahiye.
Thank you.
One more thing that I want to add, if it's a great idea, if we would able to invite any government officials or someone from the health department of India into the conferences, and let them know about what type 1 community is doing, and what the all the clinicians, all the type 1s advocates who are doing so much great things in our country, and having this awareness as well. So that would be a great platform by inviting them to the conference, and ideally reaching them, so that we can have a essential accessibility to the insulins and glucometers for the type 1s.
Exactly. Thank you so much, Chavi, for sharing those points. Definitely, we should try calling as many health professionals or health ministers into the conference, so that they know we exist. That is the first fight. So definitely, thank you so much. And now, Dr. Meenal, over to you.
Thank you, Mehak. First of all, listening to you all and being here really makes me feel very, very minuscule. I think we still need to learn a lot about type 1. So please come over to Jaipur and teach me rather everything that you can. Dr. G.D. Ramchandani sir has already said that he's standing he's holding my back actually. And I'm a bit shaky that yes, it's a huge conference that I'm organizing at Jaipur. So with all your support, I believe it will go as a big success. I have shared my personal number in the chat box. So please directly message me with all your suggestions, which I would try to incorporate the maximum in it. And as one very beautiful thing which was really brought up and which was in my mind also, before you all come to Jaipur, just brace yourself up, keep yourself geared up and volunteer yourself. We will try to establish that system of making one ambassador of TIEUP in at least one district, or maybe at least state-wise, few in each state. And we can really hand over the hierarchy of teaching, educating to you, because we as doctors might fail at times to educate all of the type 1 because we really don't live with it. So we do miss certain important aspects to even understand you at times. So maybe we can still bring the people, our patients, and all of you together state-wise, and then of course country-wise, and then globally. So that is one important thing. Please volunteer yourself to be one of the educators, then train the trainer programs can be incorporated. And make sure, as Dr. Bansi said, that you all are there in Jaipur on 7th and 8th of December. And please, please positively let me know what all best can be done on all the forums. Like we will be incorporating all the health, associations, the foundations. Even we have invited of all the PG students who are going to be future doctors of tomorrow. So education begins from educating the doctors also. We have also thought of inviting the families, the parents, because at times the children are very small to actually know and learn anything. So let the parents learn. Then, of course, we have the high legendaries who will be attending and who will teach us. So we will have all the 4 platforms running parallel, the teachers, the senior doctors, the foundations, and the parents. So please do attend, do come, and be my guest. Thank you.
Thank you, Dr. Meena.
Thank you, ma'am.
Thank you, Dr. Ramchandani, sir. So we are all geared up for tie-up this December 2024. And with this, we come to the end of the session. And I would like to thank all of you in place of Dr. Manisha. She was traveling. She couldn't do it in person for all of you. So I would have started with speakers, but today I decided that first I need to thank all the audience. Thank you, Dr. Anju Mani ma'am, for joining. Thank you all the other groups for joining. Thank you, Harsh Bhaiya. Thank you, Sumit, Jazz, Dr. Suchi, Chavi, Jyotsna. You're all joining showed that we all are together in this. And it is not about an organization. It is together for the cause. So thank you so much for this. Next, I would like to thank Dr. Partha. I know what Dr. Partha has done in technology in UK. We stand very far off, but I am sure with all the support we are getting from our doctors, we will be reaching, in fact, we'll be defying UK and going way ahead from that. I trust in my doctors and my community more. Definitely we'll be seeing this change in India also. Next, Dr. Banshi, what you are doing by taking India to world and bringing world to India, we all know that, and we want to thank you from the bottom of the heart. Dr. Archana ma'am, thank you for being a sport and taking all us young kids under your wings. You are truly Archana Ma, like you are famously known as. And last but not the least, I would like to thank Dr. Amit for coming up with this brainchild of Empower Type 1 and bringing everyone together. So thank you so much, everyone. Now let's get up for meeting all of us. Let's all meet up in Jaipur, TIEUP 2024, 8th and 9th December. Thank you so much.
Mehak, it is 7th and 8th.
7th and 8th.
7th and 8th December. Sorry. My apologies. Thank you.
I'll just add to this. So for all of you who are present here, the doctors, esteemed speakers, as well as the community members, this is your space. Okay, so we would encourage everyone, whether now you got an opportunity to speak or later on, to keep connected with everyone. Directly send in your suggestions to Meenal ma'am. Reach out to all of us. We are all here for you in whatever way we can. Let's make this a huge success, starting with the collaboration, coalition, being there for each other. And I'd like to, as Mehak has already thanked the doctors, I'd like to say that, many a times when we get diagnosed with a condition, mostly when children are diagnosed, the parents or caregivers or the pediatric endos take charge. From my experience, I was diagnosed as an adult. And looking back, I feel when we are diagnosed as an adult, we find it extremely, extremely difficult to ask for help, especially women. So today, I'd like to just acknowledge this in front of all of us, to say whatever I am today and at whatever stage of advocacy, small, big, or impactful, I'm here because of the unwavering and unconditional support from Harsh, Prashant, and Lakshmi. Whatever I am today, I'd like to really thank them and for continuously motivating me to do my best. So thank you so much. And with this, if anyone wants to say anything, or Myra, we can wrap up the session.
Yes, we can wrap up this session. And thank you everyone for sharing your thoughts. And hope to see you all at Jaipur.
Thank you.
Bye.
Thank you. Bye everyone.
Bye, everyone. Thank you.
Thank you.